I'm Carrie Firestein, Chief Executive Officer of Allied Physicians Group, practicing pediatrician for over 30 years, mother of three, grandmother of two, with one more on the way. I'm so excited to be here tonight to talk about this really very important topic. A few years ago, when my daughter was getting married, I needed to go for a mother of the bride dress. So we went into a place and we parked, and my daughter saw a Dunkin' Donuts on the corner. So I went in ahead of her. She picked up some munchkins. She came in. And when she walked in, the sales lady looked at her and said, "Well, I guess you have time." And we said, "Time for what?" So she said, "Well, time to diet for the wedding," because she was eating munchkins. And my perfectly proportioned, wonderfully weighted daughter cringed inside, not so much because it bothered her, but because she is a nutritionist who specializes in eating disorders. And she understands how a comment like that could trigger so many of her clients. And when you think about the diet culture that we live in our world, where a stranger has no problems mentioning, whether somebody should or should not be dieting for a wedding, where shedding for the wedding has become, just a standard topic, where as pediatricians, we know that there are 8-year-olds that come in and they don't like the way they look in the mirror. So this is really a very important topic for pediatricians to learn about. So I'm excited to hear about it, and for parents as well. I know parents talk to me with children as young as 2. They want them to eat healthy, but they don't want them to learn that there are good foods and bad foods, and how do they differentiate. And, for every child who we think is eating too much, then we worry about children that are eating too little. And it's so much a part of a parent and a grandparent to want to feed their child. So to learn how to do it the right way and to create good, healthy children is why we're here tonight. So I'm going to let our panel introduce themselves, and we're going to start with Dr. Eric Levine.
Hi, I'm Dr. Eric Levine. I'm a practicing pediatrician for 30 years in White Plains. I'm a father of 2, and I'm interested in learning from the panel because we have lots of patients who asked us all these questions. I'm also here to answer anything from a general pediatric point of view, but also probably ask more questions than I can answer.
Thank you, Eric. Dr. Levine.
Hi, I'm Stephanie Levine. I am a doubly boarded adolescent medicine physician, also boarded in general pediatrics. And I am currently working at Atlantic Health in New Jersey. And part of my responsibilities is I'm one of the medical physicians in the eating disorder program that we have. I have 2 daughters. So again, like Dr. Firestein, very sensitive to having healthy daughters and children, and it goes a long way. And I'm very excited to be here tonight because I do think it's an important conversation that it needs to go out to the community, to parents, to both medical and non-medical people. So thanks for having me.
Dr. Levine, you have daughters, so you mentioned daughters, and we used to worry, more about our girls, but I know in my practice, we are seeing more and more eating disorders with boys as well.
Absolutely.
Dr. Feehan.
Hi, good evening. My name is Letty Feehan, and I am a licensed clinical psychologist specializing in children and adolescents. I have been practicing as a psychologist for nearly 20 years. My background is specifically in eating disorders. I was trained in Mount Sinai in their eating and weight disorder program. And now I am the program manager of the Pediatric Eating Disorder Center at Atlantic Health System, and also work as a psychologist within the program seeing patients as well.
Great. So before we get started, I just want to let everybody know that we are going to be recording this and we will send it out to everybody with an email in the next few days that includes any of the resources that we mentioned. So you don't have to worry so much if you don't understand how to spell something. And also if you have somebody that you want to forward this to, feel free.
So we figured that we would keep this relatively informal in the sense that we want people to be able to ask questions and we want to be able to answer those questions and really have a discussion. I did think that we would start with a very brief PowerPoint presentation, just because I want to walk you through the specific diagnoses for eating disorders, so we have a general understanding together of what we're referring to, as well as just touching base on some of the psychological warning signs that we see associated with eating disorders. So I am going to figure out how to share my screen, which is not apparently as easy as I thought. So you might not get the PowerPoint.
Dr. Fian, you can
Yes.
click share screen right at the bottom, and then it should pop up as long as you have your PowerPoint open.
Do we see it?
Yep.
Yeah. Okay, perfect. Okay, thank you. I was missing that button. Okay, so first I would like just to speak globally about eating disorders. And so I think it really is an important statement in that eating disorders are potentially deadly, biologically based and treatable mental illnesses. So a lot is sort of packed into that statement. So the first piece that I want to touch on is that these illnesses are genetically loaded, and they really are based in some biological predisposition. And so later on in the webinar, I'll be happy to go into that in greater detail. But I think it's one of the things that I really always want parents to understand, because one of the questions that we get when parents come to us for the first time is, what caused this? And can we find the root cause so that this never happens again? And so the answer that, I really like to share with parents is that, listen, there are a series of psychosocial factors that might essentially pull the trigger. But we know that individuals who develop these illnesses have differences in their temperament style and differences in their brain that really make them hardwired to develop these illnesses. But the other thing to understand too is that these illnesses are treatable. And I think that's a really unique feature for eating disorders, because I think when we talk about mental illness, usually we talk about how to manage it. So if someone has depression or anxiety, it's really with that person, but it's learning how to, again, manage the symptomatology associated with those mental illnesses. The difference with eating disorders is that there is really a cure for these illnesses, and that individuals are able to sustain a full recovery. So when we look at the different types of eating disorders, the first one that we will discuss is anorexia. So anorexia, I think that historically people view anorexia in terms of an individual who is not eating. A lot of parents, when they come to us for the first time, will say, my child can't have anorexia because they're still eating. And in fact, many of these individuals still are eating, but what they're eating is severely narrow in repertoire, or limited in calories. So in order to be diagnosed with an anorexia, an individual must be restricting their energy intake, food, resulting in significant low body weight for that individual. And so I think the thing that's really important here to note is that significantly low body weight is really a clinical decision point. So in the past, with our what we used to diagnose eating disorders in the past, there used to be a set weight criteria. Individuals had to be what was referred to 85% or less of their expected body weight. And because there was really this sort of like specific criteria that needed to be met for weight, a lot of individuals were not properly diagnosed. So specifically what we saw is that younger children and adolescents, they might not actually lose a tremendous amount of weight. Even if they do, their reserves are so little that for them, 5 pounds could be catastrophic in weight loss. Alternatively, we tend to see that children and adolescents might be more stagnant in their weight. So for example, we have someone right now in our center who is a 13-year-old male who has not gained weight for 4 years. So it's not that he lost weight and is now significantly underweight. He failed to gain weight over the period of 4 years. And so that's really the point that, I think, and Dr. Levine will touch on even more, is that for an individual to not gain weight during adolescence is something of immediate concern. So again, there's no specific threshold that someone needs to be. It's being underweight for them. In addition, there's also an intense fear of gaining weight or a persistent behavior that interferes with weight gain. So when you talk to individuals who we suspect meet criteria for anorexia, they may tell you, believe it or not, that they don't have a fear of gaining weight, but the behaviors that they're engaging in are inconsistent with what they're saying. So it's this behavior as well. They don't have to verbalize it, but they have to be engaging in some sort of behavior that prevents them from gaining weight back. And finally, there is some disturbance in the way that they're viewing their body. So some individuals have what we refer to as body image distortion. So they may see their bodies inaccurately. They may perceive themselves as overweight or perhaps just as normal weight, even despite their emaciated appearance. Alternatively, there are individuals may really see their shape and appearance and weight as the main driving factor in how they view themselves overall as a person. And then more often than not, individuals who are eventually diagnosed with anorexia really have a lack of recognition of the seriousness of their low body weight. So they are oftentimes in a place of denial when they come to us, and that can also persist for some time. So, there we go. So the general population, the prevalence is about roughly 0.5% to 2% of adolescents. We do see that, as you mentioned earlier, that there is an increase in males being diagnosed with this illness. So the ratio in our older adolescents and young adults is 10 to 1 for female to male. In our younger patients, it's more like 4 to 1. And I think that, really what happened is that there was a shift over the past 10 years or so where the criteria for anorexia became more inclusive. So it used to be that in order to be diagnosed with anorexia, you had to miss 3 consecutive menstrual cycles. So clearly that eliminated 50% of the population. So males were often misdiagnosed or rather underdiagnosed. So I think now with the change in the criteria, we are seeing males being more accurately captured under the category of anorexia. The average age of onset is 12. It does seem to be commensurate with the onset of puberty. And as we mentioned sort of in the intro, that these can be fatal illnesses. So roughly between 5 to 20% of individuals struggling with anorexia will succumb to the illness. About half of that is attributable to suicide, and the other half are medical complications related to the illness. And, as previously stated, oftentimes there's really this lack of awareness that something is wrong. And because of that, oftentimes a lack of motivation for recovery. These individuals may not want to engage in treatment, and treatment, they will find it, extremely challenging because despite the fact that, even if they do have some awareness as to their illness, they really don't see it as affecting sort of their day-to-day. And there's also, again, that persistent fear of gaining weight that really impinges on their desire to recover. So bulimia is essentially when an individual engages in binge eating. And so when we look at binge eating, it's really sitting down and eating an exorbitant amount of calories in one sitting objectively. And I say that because there are individuals who will tell us, oh, I binge eat, but really they ate a couple Oreos. So binge eating means that I'm eating an excessive amount of food in one sitting and I feel a loss of control while I'm doing that. And then these individuals then engage in some sort of method to prevent the weight gain from it. So typically, I think people think of compensatory methods as purging, vomiting, which yes, that is the case, but it can also be exercise use. It can also be laxative and diet pill use as well. So in order to be diagnosed with bulimia, an individual needs to engage in that binge purge cycle at least one time a week for 3 months. Much like what we see with anorexia, an individual really evaluates their self-worth, largely focusing on shape and weight. And the one key thing to really understand is this is a distinct illness from anorexia. So I have heard some individuals say that, you know, in the past they were diagnosed with anorexia and bulimia. So really, you can only meet criteria for one at a time. So if you're engaging in behaviors, we really look at what are the predominant behaviors that you're exhibiting at that time to capture which diagnosis is more accurate. The prevalence rate is about 1%. It's often more common in females, although males might be more likely to engage in the excessive exercise piece as the compensatory method. Similarly to anorexia, we see the age of onset is around age 12. Oftentimes people with bulimia really will tell us kind of that they struggle to feel that their illness is validated because they don't appear to be struggling with an eating disorder. So these individuals may be of average weight, they may be overweight. There's definitely fluctuations within their weight. And so because of that, they don't feel necessarily that they are, let's say, you know, I don't necessarily deserve treatment, or I'm not as sick as other people, or maybe my illness is just not as legitimate as anorexia. The key difference, though, is that individuals with bulimia, and this is not all the time, but by and large, individuals who experience bulimia are oftentimes more motivated for treatment. And the reason really being is that they understand that the behavior, specifically purging, is perhaps detrimental to their health, and they view it as aversive. And so because they view it as aversive, it's something that they are willing to gain the skills to be able to interrupt. Then I'd like to touch on what is, we call it a new diagnosis, and new now sounds kind of silly because it's been around now for 9 years, but it is still somewhat new. So this is known as avoidant restrictive food intake disorder, or otherwise known as ARFID. So ARFID, again, so with our new diagnostic manual, emerged this diagnosis for likely an illness that's been around for quite some time. So here, the key differential feature is that these individuals are not getting their nutritional needs met, which may result in either growth stagnation, weight stagnation, or weight suppression, but it's not due to any body image concerns at all. Very different features for this illness. So there's 3 different sort of categories within this broader diagnosis of ARFID. So first of all, you may have individuals who have seemingly minimal interest in food. Parents will report that from a very early age, these children just seemingly weren't interested in food. They wouldn't sit down for meals. They might be sort of your grazers throughout the day, but seemingly if they were not reminded to eat, they might not. Another category within ARFID are those individuals who have significant sensory aversions. So individuals in this category have historically have very limited repertoires on what they eat. And I don't mean sort of like your standard, I go to, you know, a restaurant and there's a kid's menu that I can find chicken fingers and French fries. I mean, these kids will have maybe, you know, 3 to 5 foods that they eat regularly, but they're very specific even within those foods. So it's not just that I'll eat pizza, but I will only eat pizza from Domino's that's heated at 180 degrees. And I can taste the difference if you're going to give me Pizza Hut. The theory is that these individuals are somewhat super tasters, so they can really distinguish the minute differences between different foods. And so because they are not getting their nutritional needs met, obviously it results in underweight status. The last category are those individuals who probably have been somewhat normal eaters throughout their life, but then have an aversive experience. So the experience could be a choking episode, it could be a vomiting episode, either they or even commonly we see individuals who witness a vomiting episode of someone in the cafeteria. And because that happened, they then start restricting their intake because they don't want that thing to happen to them. So again, that's sort of a more acute onset of what we see. So these individuals overall, they want to gain weight. They are so excited when they are gaining weight because they know that they're smaller than their peers. What we do know, though, for these individuals is that sometimes it can be really hard in the later stages to determine whether or not an individual is suffering from ARFID or they're suffering from anorexia. And the reason why is because once the brain is malnourished for a period of time, the symptoms of anorexia develop just from that malnourished state. So individuals who may start off as having ARFID can sometimes transition into anorexia because their brain is not being nourished appropriately. And then finally, there's sort of this catch-all category. It's known as other specified feeding or eating disorder. So basically, if an individual doesn't meet the criteria, doesn't fit nicely into one of those other categories, they are given this diagnosis. And I think one of the most common individual types that we see that really falls within this category are those individuals who are significantly overweight, truly significantly overweight at baseline, lose a dramatic amount of weight in a short period of time using restrictive behaviors. And instead of individuals being concerned that they have anorexia because they're now of normal weight or maybe even slightly higher, people are saying, congratulations, you did a great job. But in fact, these individuals suffer from the same psychological and medical complications because of the manner of which the weight was lost. So typically, just in terms of how we see eating disorders present, I'm going to touch on some of the psychological features. They're pretty common and shared among anorexia and bulimia with a few nuances. So individuals who have anorexia are really preoccupied with thinking about food or calories. It really consumes them. They think about, when their next meal is, the timing of meals, what they're going to have. And sometimes what we also see is that these individuals then become preoccupied with feeding other people. So they might be all of a sudden researching recipes. They might be cooking for their other family members, not eating it themselves, but preparing meals for other people in their family. Again, there's a refusal to eat certain foods, or more specifically, food groups. We tend to see a very specific pattern where individuals begin by restricting junk food or sugar. Then that might expand into other categories, carbs, seemingly the enemy lately. We also see a lot of individuals who become vegetarian or vegan, but it's within the context of the eating disorder, as well as we see a lot of dairy intolerance that was not present before the onset of the eating disorder as well. Individuals will often refuse to eat publicly with other people. So we see that they start to not socialize as much with their friends because obviously of the food situations that might present. They might not eat at mealtime with their family anymore. There might be comments about feeling fat or, definitely comments about body image in general. These individuals will often engage in rituals around food. They might cut food into very small bites, push food around the plate, take a long time to eat. as well as having body image rituals, excessively looking in the mirror, feeling different parts of their body. For individuals, oftentimes there can be an exercise piece. So what we see is that the exercise can absolutely be excessive. Many of these individuals are athletes, and then once they are done with their practices or their games for the day, they're coming home and they're doing additional exercise. They're setting alarms in the morning to get up before school in order to exercise. And when you ask them, they discuss it as somewhat compulsive, that they feel this driven desire to do this, and if they don't, it's going to result in weight gain. Again, there is withdrawal from friends and family and activities and things that really they used to enjoy. Initially, you'll see somewhat increased anxiety and depression. Parents will describe their children as irritable. And really at the most sort of acute stage, we tend to see what's known as really just a flat affect. So these individuals will have delayed processing, and that really speaks to the changes in the brain. So it's really hard for them to find words sometimes, and they'll just be somewhat expressionless. And the bulimia, again, is very similar. I guess the real differences here being that parents will report that there are large amounts of food that go missing from the kitchen. They might find it in the child's bedroom. They might find evidence of it, wrappers and what have you. There might be frequent trips made to the bathroom after meals. We've definitely had many parents find evidence of vomit stored in individuals' rooms, as well as there might be, if there's laxative misuse, parents may find that is something that's being overused by their adolescent as well. So with that, I'm going to switch it. I'm going to stop sharing, and I'm going to switch it over to Dr. Levine to talk about some of the medical features of eating disorders.
Thank you, Dr. Fee. And so, hi, everybody. So first, I'd like to say that I think as pediatricians, we have become much more attuned to mental health issues over the last 5 years, especially in the age of COVID. But I think that to this day, eating disorders continues to be underdiagnosed by pediatricians. And I think that that's something that I just want to alert everybody to. And really, as a pediatrician, we were taught over and over again, and it's so true, that growth charts, okay? So meaning that so many things can be identified as we're talking today about poor growth. And it's very interesting because medically, we often get referrals, believe it or not, from gastroenterologists for children with chronic abdominal pain, losing weight. We get referrals from cardiology, obviously, for kids with chronic dizziness, orthostasis, which means changes in blood pressure and dizziness and heart rates. And the physical immaturity of children and adolescents pose very unique physiologic risks. And that's something that we understand. So, I think it's really important as parents because you're with your kids. Your pediatrician is probably seeing your preteen, your teen once a year unless they're sick. And obviously when they're sick, they're not always looking at the growth charts. But it's so interesting to us that, kids come into us with a 40-pound weight loss, and the parents sort of just noticed it towards the end, that clothes were really baggy, and they're starting to see more of the physiologic changes, the dizziness, the fatigue, the withdrawal, the, not wanting to eat meals, as Dr. Fian was saying, with the family and things like that. So we all have to really pay attention to what's going on with our kids and not just assume that it's normal that they're pulling away because they're teenagers or preteens or et cetera. We really do have to pay attention. And it's just a very simple fact medically that they have less body fat, and the weight loss causes malnutrition pretty quickly. And the thing that we also worry about is the interruption of puberty. This is, time in their life where they're supposed to be growing and changing. And, the antennae need to go up if they're not. And as Dr. Fian said, sometimes it's weight loss and sometimes it's just failure to gain weight and failure to grow, failure to go through puberty, and not just presuming that they're just late bloomers. So then, I like to specifically talk about what the medical complications of eating disorders that we worry about and we see. So Dr. Fian has already alluded to, and I kind of go from top down. We know that there are changes that occur in the brain with significant weight loss and malnutrition. There are biochemical changes that occur. So these kids, even though they may know that they're hungry, and some of them will tell us they're hungry, they know they're hungry, they know what they need to do, they can't. They really can't make the changes. It's been well studied that there's atrophy of the brain that occurs. We do not typically do scans on our kids, but that has been done in certain centers. That does come back with weight restoration and better nutrition. We obviously, a big one is we see cardiac changes. So what do we worry about? Low heart rate. And basically the body just sort of conserves everything it can. So we typically will get referrals for kids who have low heart rates. And low heart rate by definition, as parents, is, well, medically it's under 60. Of course, we have a lot of our patients who are athletes, and we get parents who come in saying to us, well, we all run low heart rates, we're all runners, and we have to look at them and say, heart rates of 35, 40, not normal for anybody. So very often we have kids who are being seen at the pediatrician with weight loss, and the pediatrician is actually surprised because the heart rate, all of a sudden is 45. And that also helps us. We're not really going to talk about this today, but how we determine what kind of care, treatment, inpatient, outpatient patients need. Again, so what do we do with these patients with low heart rates and bradycardia? We rest and we feed them, and we very clearly say, your medication at this time is rest and eating. It's also very interesting because a lot of our recommendations include exercise restriction, totally. And I always like to say, medically, obviously, we do that when we see a low heart rate, and also because they need to gain weight. We need to conserve whatever intake and caloric intake they're taking. But it's also a big psychological purpose. We don't want exercise and worrying about what they're eating, how much they have to eat extra if they're playing a softball game or whatever. So we really do that exercise restriction twofold for medical reasons and for psychological reasons. And that's really important. And that's one of the hardest things I think with our anorexic patients, we have a hard time convincing parents. Parents will say to us, but exercise is so mentally good for them, and their life revolves around their exercise and their teams. And we really have to do a lot of convincing of your child is sick, psychologically and medically. This is not a punishment, and everybody's goal is to get your child back to doing what they love to do without worrying about everything. Electrolyte imbalances, that means chemicals in the body can have all sorts of craziness. And the one thing that we really worry about when we initially see a patient with a significant weight loss who's been restricting, and we have a lot of patients who come into us eating maybe 300 calories a day, 500 calories a day. So it's been well studied that you cannot actually give too much food too quickly. There's something called refeeding syndrome that we worry about, where you can get all sorts of crazy electrolyte imbalances, which can actually lead to death. And I'm not saying that to be dramatic. That is what we worry about. That's been well studied there were studies done in POWs who kind of got out of the camps and, ate whatever they could, and they actually died. So we're very conservative when we have somebody who's lost a lot of weight and has been severely restricting. We increase their calories as we have a protocol that we use very slowly, drawing blood. And that risk is usually for the first 2 weeks that we start to get them back to eating normally. And it's very interesting because very often during that period of time, there's not a significant amount of weight gain because we have to be very careful, and parents can tend to not understand that we can't go any quicker at the time. You can get, kidney can be affected. That's from dehydration and malnutrition. We can see endocrine changes. There's something called a low T3 syndrome, which is just, again, the body conserving all its energy that it can. Again, all these things will be corrected with weight restoration. One of the things that we're never 100% sure of how it will be recovered is bone health. And, one of the most common presentations that we may see is we may get a referral for a young woman who loses her period. She's had her period and all of a sudden, and the first thing I look at is the growth chart. Is this child coming to me, this young lady coming to me because she's not getting her periods anymore? And the first thing you look at the growth chart is she's lost 25 pounds. So it's just another red flag to asking the right questions. So when you do not get your period, it's very important. Between the ages of 11 and 21 is when most people are laying down all the bone for the rest of their life. And we try and explain this to parents that it's so important that they get their period back. So we never know. We usually will recommend a bone scan if they have not had their period between 6 and 12 months. And we use a little bit of art to that, if you will. It depends how long they've been sick, how much weight they've lost, how old they are, how long they had their period. But typically, if they have been amenorrheic without a period for 6 to 12 months, we recommend a bone scan. And then whether it's normal or not normal, we will repeat that in 2 years because sometimes there's a lag in the results. Sometimes they're worse 2 years later and sometimes they're better. And the question we always get is, why don't you just put them on a birth control pill and give them some estrogen back? It just doesn't work that way. Really, treatment for that, again, food, getting them back to a healthy weight. And I like to just interject at this point because I think it's important that we all understand when we talk about a healthy weight or what we call an estimated ideal body weight, there's no formula. There's no magic, formula that we plug in. Really, we look at the growth charts again, and we look at the individual's trajectory where it should be. So we look at the height, we look at the weight, and we just want to get them back on their own growth charts. And that's very hard to explain to parents sometimes. They'll say, oh, they've never been this weight, or, oh, we've always been at this percentile. We look and we want them to get back to where they always were and should be again. That's where the health will be restored. Other medical complications, you can get low blood counts, anemia, and of course, psychiatric comorbidities. And I can let Dr. Feehan talk about that a little bit more, but we do see associated anxiety. And it's really hard in the beginning. I think one of the most difficult things we have in the beginning is sort of pulling out what's coming first, the chicken or the egg. Is the anxiety due to the eating disorder? Is the eating disorder due to anxiety? But we know when somebody's severely malnourished, it's very hard to make that correct decision right away. So we actually wait a little. We don't usually medicate right off the bat. Dr. Feehan can add a little bit to that. We do work in our team with psychiatrists, psychiatric nurse practitioners, and they're followed. And then sometimes as they become more weight restored, as we say, we start to see different features come out of other psychiatric disorders, and we do address those at that time. So once again, it's really, impact on growth, puberty, cavities, patients presenting. Like I said, very often it's weight loss. I do like to say that it's very interesting to me, having been doing this now for a while, is we know that the sicker patients or the sicker kids coming in, it's either, to me, it's one of one of two things. It's acute weight loss. So even if they've lost, and sometimes we see kids who come in, they're down like 60 pounds in a year. Maybe they started out a little bit overweight. And maybe for the first 4 to 5 months, they lost 10 to 15 pounds. But then it just takes off. And usually they get to us with the low heart rate, the malnutrition. They've lost like another 20, 25 pounds in a very short period of time. And we do find that those patients tend to be sicker. And but there's no rhyme or reason. You know, sometimes we have patients who lose a significant amount of weight over a year, and they're just as sick. So we don't have all those answers, but we know what we have to look at. We know what we need to do, and then we just make the decision when we do our evaluations. And just so you know, at our center, we do an evaluation with mental health and medical. We do it together. And really what we do at our center is we make these evaluations and we decide whether they're appropriate for the type of treatment we do, which I'm going to let Dr. Feehan speak a little bit about, because I think it's really important to know what we do at our center specifically. And then we make a decision of whether that patient needs to be hospitalized for medical stabilization. That's not a psychiatric admission, that's a pure medical admission. And then we decide whether they need what we call a higher level of care. Do they need more of a structured inpatient eating disorder hospitalization, or whether they can come to a day program like we have. We have a partial hospitalization program where they're with us during the day but go home at night and on the weekends, or whether it can be outpatient, and that's you know, with a team set up. So Dr. Feehan, maybe you'd like to just talk about what we do specifically, our modality of treatment?
Sure. So really when we talk about the different types of treatment, we're looking at, not, as Dr. Levine mentioned, not necessarily where the individual is being treated, what type of setting, it's the modality of treatment. What are the mechanisms that promote change? And so there's really two main modalities for treatment for eating disorders. The first of which is a more, what we refer to as the traditional model. So the traditional model really has the individual with the eating disorder sort of driving the change. So they might meet with a nutritionist themselves, a therapist, and they are the one that is actively trying to make the changes in order to gain weight. And then the other modality of treatment is something that's known as family-based therapy. And so that is the type of treatment that we do at our center. So FBT, the acronym. So FBT is really the only evidence-based treatment that there is for specifically anorexia, although it is used with bulimia as well. What it does is it takes that off of the individual, and it really empowers the parents to be able to refeed their child and get them back to a place of health. So temporarily, the parents are responsible for taking over control over all of the child's meals, meaning that they are choosing the meals, they are preparing it, portioning it, supervising it to ensure completion. And so again, really the goal is for the adolescent, the child, to have brain rest from having to make those decisions around food by putting the parents in charge, and really promoting rapid weight loss, weight gain, not weight loss, weight gain. So again, the key to full recovery, as Dr. Levine mentioned, is weight restoration and getting that brain back to the nourished place. And that we know that the more rapidly an individual can do that, the better the prognosis long-term. So if you think about it from a developmental standpoint, I didn't put in my intro, but I am also the mother of 3 children. And, you know, my children, I mean, I'm still preparing a lot of their meals. I'm overseeing what they're eating. So to then have them meet with someone on their own and say they are responsible then for making the changes isn't really just in line with where they're at developmentally. But besides that, we're also saying that a malnourished brain doesn't think accurately about food. So if we're telling an individual, okay, go ahead and make these changes, they might sit and say, okay, that sounds great, I'll make these changes. But when they go home, there's no way. So, again, it's really putting the parents in charge temporarily until the individual can become healthy enough from a mental perspective, where then they can gradually begin to take some control back over eating again and return to a more normative way of eating. So it is definitely a hard treatment. It is a lengthy treatment, but it is so because it works and because it's really miraculous when you see kids who do this type of treatment. There's just sort of this light bulb that goes on when they hit this healthy place for them. And it really, their thinking begins to shift. And it's so remarkable when you can see that.
Thank you. This was just also very interesting, but let's take a step back a little bit, because we had some questions coming in and a lot of them were a little more about either prevention or how to, as a parent, before you suspected an eating, or before there's an eating disorder, what should you do? What should you suspect? So one of the questions was, are there triggers for an eating disorder? Are there things that parents should or shouldn't do with their toddler, with their elementary school child, with their middle schooler? What would you say about that?
Yeah. So I definitely think that, as we kind of touched on in the intro, in that really we want to make sure that foods are not, they're not put into these dichotomous categories. So foods are not good and bad. All foods really serve a purpose. And so, and really what we look for is all foods in moderation. So where we see it sort of go awry is for parents that are significantly limiting what their children are eating in terms of certain categories of food. So not allowing access to junk food in the home, or not allowing the child to have desserts and what have you. So again, it all goes back to moderation. So fine. So you're not going to feed your child cake morning, noon, and night, but we also want them to know that, listen, that cake is fine. And it doesn't have to be about this health benefit. It's cake is social. If it's someone's birthday, we have cake. So, cake is not bad. And, what the studies have shown is that where individuals who grow up in these very restrictive households have a tendency to binge later on down the road. And I will tell you that clinically, many patients will tell me, I didn't have access to this food when I was younger. My parents told me that it wasn't okay. And the minute that they go to a friend's house, guess what they're eating? So as soon as they have access to it, they tend to go overboard with it because they've never learned how to appropriately manage it. And so I think that's the idea, that nothing is off limits. It's about setting sort of, again, this balanced way of eating. And I think also just promoting, promoting what does being healthy mean? A lot of the individuals that we see equate being healthy eating with low calorie eating. Low calorie foods are not healthy. I mean, that's just not what it's not about the calories. And so, understanding that as a parent too, what you do as a parent, your children are constantly watching you. So even if you yourself are not saying, okay, foods are bad, foods are good, what have you, if you're sitting at a mealtime and you are, eating in a way that you're avoiding certain foods, the kid is going to pick up on that. And we know that these kids have a vulnerability, that they really are, they're rule followers, they're good kids, they really look to authority to know what to do. And so whether they're in a classroom setting where they get messages, which happens a lot, or they're at home and they get messages about these foods again, or they're witnessing it, that starts to create this unhealthy relationship with food.
And I just wanted to add in, as you were speaking, Meg, first of all, I do believe as a parent that mealtime is extremely important, to sit down and eat as a family. And I think that that's was going by the wayside. Perhaps with COVID, it came back a little bit again, but I do think that's really important. And also as a parent, to say to your kid, you know, I eat this way for a reason, for whatever it is, whether the parent is overweight, is pre-diabetic, you know, is training for a marathon, but you're my child and I know what you need, and it may be different than my needs. Because we hear that all the time, like Dr. Fian was saying, is that they just see what their parents are doing and they think that's the appropriate way to do it, and we know that it's not. So it's really just making a decision as a parent, you know, to explain everything in moderation. Listen, we know there are families that choose to be vegan. Well, you can be vegan and eat enough, you know. We know that there are, you know, certain philosophies that people have, but if you're doing it as a family and it's all very healthy and in moderation, I think it's great.
So Dr. Stephanie, you know, one of the questions was, you know, sometimes children do need to, I don't want to say they need to lose weight, right? They need to grow into their weight, or, you know, the American Academy of Pediatrics just came out with these new obesity guidelines. There's all this emphasis on that. You know, how does a parent help their child to figure out how to navigate that without cutting calories or decreasing, avoiding food groups and things like that?
I'll tell you what I usually recommend. You know, first of all, the first step is you see your pediatrician. And I've said this before in so many talks that I've given. You know, your pediatrician becomes part of your family, really. Just sitting down with your pediatrician and maybe looking at the growth charts and explaining, you know, a child who's 13 in a group of 13-year-old girls, they're all different sizes, they've all in development at different times. But one child is just comparing herself to everybody else in that group. And I think it's really important as a parent and a pediatrician just to say, this is where you are, this is where you need to be. So to the point, you know, we do have to be, I don't want to say careful with our words, we have to be kind with our words as pediatricians. So if there is a child who put on 20 pounds during COVID, you do have to have the conversation, but then teach them, you know, you can recommend books on healthy eating in teens and why it's different than an adult. You can listen. Have I said to parents who are really struggling with their own weight and then they have an overweight child, perhaps you see a nutritionist once. You don't have to go all the time. Go once and get educated on what healthy eating is for a teen. The nutritionist will, you know, look at, you know, the amount of exercise they're doing, and they'll see the family history and how the whole family eats. But as we know, not everybody can afford that. So I think you really have to know your patient clientele. But I think having a conversation about what healthy exercise and eating is, and being on top of that kid who perhaps put on the 20 pounds, and really saying, you know, we're going to check in with the pediatrician every 3 months for the next year to see how we're doing, instead of just waiting a whole year. And then guess what? They lost the 20 pounds and then another 15. Do you know what I'm saying? Because it's gone awry. Because as Dr. Fian said, we know there's a genetic predisposition that certain kids, they're perfectionists, their brain works a certain way, and they take everything to the max. So they're going to take this weight loss to the max. So I don't like the word diet. I never have. It's about getting back on your growth charts, learning again how to eat healthy, have a good amount of activity in your life, and without worrying about it. I think that's the whole philosophy behind therapy, is to find the balance without constantly worrying about what you're eating and how much exercise you need to do to compensate, or vice versa.
If I could just add real quick, I'll be real. So I think that just two points I want to make is that I think that oftentimes what we will see, because if you saw when I talked about the age of onset, about, you know, it commonly being around 12. So I think for parents to understand that when their child goes through puberty, there is a normal process of weight gain, and it is very common to see individuals jump percentiles on their growth chart. That is temporary. That is temporary as a result of puberty. And what we'll see is that, obviously over time, over a couple of years post puberty, the individual will naturally come back down to what their growth chart was. And I think we have seen definitely a fair amount of children who see that bump up in weight, or maybe even their parents see that bump up in weight and get scared. And that's when the restriction begins. And I always tell them that had you allowed yourself to go through the natural process, you would have seen that you would have come back down to where you were meant to be. But they don't, because the eating disorder develops. The other point that I will make really quickly, and this is going to be maybe an unpopular opinion, but I think it's fair to say that there are some individuals that are meant to be in the higher weight categories. It's genetic loading. And so if you have an individual that's always tracked along the 90 percentile for weight, they're probably meant to be on the 90 percentile for weight.
Absolutely.
So Dr. Eric, somebody's listening to us, they're concerned that they're not sure what they're seeing in their child, whether it's restriction or weight loss, and they call their pediatrician. What's the next step?
The next step is to come in. And as Dr. Fian and the other Dr. Levine said, is let's get a weight. Let's look at that growth chart. Let's check their height, check their heart rate, check their blood pressure, look at their vitals. And then the more important thing is to have that conversation. What's going on? Are you doing sports? Are you, how's mealtime going? And a lot of times, and these were my questions, actually, I was going to bring up is they're so influenced by social media. And how do we, a lot of parents are like, they're watching this on TikTok, they're doing this. How can I help them or give them other websites to look at? But what I like to do is, all right, have a conversation, do the growth chart, talk to them about what they're eating, what they're not eating, talk to the family, and I don't know if this is everybody, but I like to talk to the kid alone and with the parent and to the parent alone. And it's usually we send the kid to give us a urine sample so we can get a nice quick conversation with the parent to say, what's going on? What are your concerns? Hopefully I'm having a phone conversation prior with the parent as well. And then I say, all right, we have a conversation on healthy food, proper nutrition, and say, back in a month, let's see what's going on. And then we take it from there. But I think it's important for the parent to call the pediatrician and say, this is my concern. And come in. It's quite
a really
important.
Quick thing, Dr. Levine, that you can do that seriously, it doesn't take very long. We all know that we all have enough to do, and the anxiety screening, the depression screening, but take a quick 24-hour food recall. You would be surprised how much information you're going to get out of that. Because if you have, a young girl goes, well, I never eat breakfast, because a lot of them don't. And I scream at them because, they need to eat something in the morning. But do a quick food recall. If they're not eating anything until 4 o'clock, and then there's key words they say. They say a half a cup of rice. You tell me what 13-year-old is measuring out a half a cup of rice. That's not normal, especially a boy. I hate to say it, but they usually just, take it. Are they having snacks? Are they staying away from, if they start saying to you, I don't do processed foods, I'm thinking of become vegetarian. Those are red flags to me all the time. And so those are just very quick, simple questions that a parent can ask or the pediatrician can ask.
Yeah. And I'll often bring them back even a little faster than a month, because sometimes just having the conversation and then everything gets worse. Because you've now brought it to a head. Oh, we have something in the chat. Let's see what we have. What is your recommendation for the over 18-year-old young adult as far as talking to the older child regarding what we as parents are noticing? Where would the over 18 child go for an evaluation? So I'll just say that most of the pediatricians in Allied continue to see patients at least through the end of college. So if you have a relationship with that, with a doctor that's known you for a long time, I would continue to use that relationship, and they could help you figure out where to go. Dr. Stephanie, I'll let you, talk about what to tell them. I don't think you say much different from a 16-year-old to an 18-year-old, but let me hear what you have to say.
It's not. We see patients from 8 years old to 21. I think maybe perhaps the question is 18, they're of age. So I think the only challenging thing, and we see it all the time where we are, is they have to be on board. They're 18, they have to give consent. And, very often we do a full evaluation. And when we say we think you should come into program, they look at you like you have 5 heads. And unfortunately, that's really where you struggle about getting the parents on board. But then again, very often you have an 18-year-old being brought in by their parents. There's an issue, and usually the 18-year-old knows it. But they have to be on board. It's tough when they're of age.
Yeah, it is a good thing if you're seeing something, to address it, 2 years before they go off to college, because you have to deal with it, and then you don't want it to interfere potentially with going to college, which sometimes it does.
Listen, we have had patients, in July who are all set to go off in September, and we have to tell them they can't go. I mean, we don't, how we present it. We don't say you can't go. We say we don't think you should go. And then we have patients who we may perhaps start in March or April for the following year. And, a lot of the schools have resources and centers and counselors, and they'll do weigh-ins. There's a lot of resources at a lot of the colleges now, which is great.
Yeah, and I've had colleges that did not want to deal with it at all, would not even do a wait for a kid. Somebody asked, are there certain colleges, is there a way to determine which colleges will be lower risk for patients? I know my daughter hates when her patients go to a school where they're in bathing suits all year long.
I don't think so. I'm going to answer that honestly. I think, no, I don't think there's any bigger, smaller, warmer, colder. I don't think so. I really don't. I don't think that's what these kids are really worrying about, to tell you the truth.
Dr. Feehan, there's a question about emotional eating and how does that compare with binging?
So emotional eating, binge eating is one of, with the new manual that I was talking about for diagnosing, it really has come out in the last 9 years as its own sort of diagnosis. That's not something that we ourselves actually manage at the Pediatric Eating Disorder Center, because really there has not really been a conclusive evidence-based approach for it. So to really distinguish between emotional eating and binge eating, I think, binge eating is sort of the formal diagnosis, and really kind of assessing why the binging is occurring. And so the emotional eating is, are these individuals engaging in some sort of binge behavior because it's modulating their mood? And there is evidence to suggest that individuals do get sort of this high, if you will, as a result of binge eating. So to really distinguish, I guess, emotional eating is just a one of the tenets of the binge eating, which is the formal diagnosis.
So there are a bunch of questions about, what do I do with my child if I notice this, if they're eating too much or too little or anything like that. I don't want to go through them all. I would suggest if a parent is noticing something like that, that's probably the time to talk to their pediatrician, right? They shouldn't be handling it all. And then if an eating disorder is diagnosed, then there's a team that gets involved that can help you answer all these questions. Is that the best approach?
Yeah, absolutely.
Absolutely.
Yeah. And as far as, just even, I can speak to our center, obviously, that if a parent has a question and they're not sure where to turn, we have parents contact us all the time and say, my child might not be appropriate for your center, but I'm not sure where really to turn. And we're happy to offer suggestions.
So some of it can be done not
Absolutely.
necessarily attached to a hospital, right?
Absolutely, absolutely. Outpatient treatment. I see a question related to kind of what if you can't do FBT? So yeah, so to understand there's many different forms of outpatient treatment. One of the evidence-based treatments for eating disorders, it's not of that traditional model that I talked about. It's known as CBT-E. The E stands for enhanced, not eating disorders, as one might think. But that is a treatment that is often used for individuals where the family is not able to be involved for whatever reason. So yes, there's a lot of different alternatives to necessarily needing a higher level of care, and perhaps even needing the family involvement as well.
Okay, the question that's in the chat is about a specific child with binging and restricting it, and I think we're gonna leave that to that person's care team, because there's so many questions that have to be asked about this child before we could give you an answer to that. When we send out the recording, can you guys include some books or resources for people who want to delve maybe a little bit deeper into either pre-diagnosis or diagnosis, treatment, that kind of thing?
Absolutely.
Great. Okay. And then since we're past the hour, I'm just gonna ask if anybody has any closing statements. Let's start with Dr. Levine. Dr. Eric Levine. Well,
Eric.
Go ahead,
Yes.
Steph.
start with Dr. Eric.
Go ahead, Stephanie.
I was
I'm-
just gonna, for me, I was just gonna say, you certainly can contact me directly. Dr. Eric Levine has all my contact information. We are always happy to answer questions. I think some of the limiting factors is I don't know who some of the outpatient providers specifically are in your area, and I encourage you to sort of like, we have a list of therapists that we use, but they're local to us. But I think that's so helpful to the pediatricians that you work with, like to just be able to say, this is a therapist in the community who specifically works with eating disorder patients. Because if you can compile some sort of list of nutritionists and therapists, that's the first step. If more is needed, that therapist who knows eating disorders very well should be able to help guide you. But of course, you can always call us if the question is, what do we do now? We would love to help with any of that.
Well, so Allied, just so everybody's aware, has a mental health coordinator that is able to give parents the information within their neighborhood, and Allied is,
That's
very
right.
far flung. And if it's specifically about eating disorders, she will be able to help you connect with eating disorders. In order to connect with that person, you do need to go through your individual office. So either the pediatrician or the office manager or somebody there can help you connect with that. Dr. Eric Levine, any?
That was exactly what I was about to say, is that Allied has created this list of mental health workers, and the mental health coordinator has been quite helpful, speaking as from the pediatric side, in helping our patients find mental health as well as eating disorder. So contact your pediatrician. They'll be very happy to help. If you're not an Allied patient, I'm sure you could reach out to one of the Allied offices, speak to the office manager, and they'd be happy to help you and connect you in any way we can. And as Dr. Stephanie Levine said, and Dr. Feehan has said, reach out to your pediatrician. It's your first step. And pretty much, we're not there to lay blame or accuse or anything like that. We really just want to help. And if you need to talk to the pediatrician beforehand, do a telehealth just with you, just with the parent before the kid comes in, we're happy to do any of that.
Yeah, that would be an Allied pediatrician or any pediatrician.
Nutrition, right?
Dr. Feehan.
So the one thing that I would say is really just parents, trust your parental gut. A lot of times families will come to us and it will be at a point where the eating disorder has gotten quite severe, and they have observed signs and symptoms earlier on, and, but maybe, their child told them everything was fine, or, they saw some improvement here and there. But I think at the end of the day, we have that instinctual sense as parents to know that something is awry and to really jump on it as soon as you think that there might be something that is questionable.
And I think just to add to that, I was just listening to all of you. We used to believe this was all about control, and there was, we get a lot of parents who either come in feeling extremely embarrassed, extremely guilty, or extremely, just like bewildered. And the first thing I always say is, this is nobody's fault, because I think you need to make that clear. It's not about blame for the child. It's not about blame with the parents. We just want to get your child the treatment that they need. And I think we all need to remember that.
And my parting words are, you don't need to come to your pediatrician with a diagnosis, right? You don't need to wait until things are bad or until you're really sure. Come to us with a suspicion. We will watch with you. And if everything ends up being perfect, that's great. And if we end up needing to intervene, that's great. But the sooner we get started, the better it is for everybody. The less physiologic change and the less mental change, because the longer it goes on mentally, the harder it is to deal with it. Well, thank you to our wonderful panel. I know I learned a lot, and I look forward to reading some of the resources that you give us and to sending out the email to everybody who listened today. So thank you, everyone, and thank you, everyone who listened.
Thank you.
Thank you.
Bye, guys.
Good night.